Our objective was to use all of BC's linked provincial health administrative data, keeping in mind it's a universal healthcare system, single payer system, so we truly do have a full population. And we wanted to compare the performance of the two primary modes of treatment for opioid use disorder that we have. So methadone, aqueous methadone with buprenorphine naloxone. So I'll preface this by saying two things. First, unlike the US, methadone and buprenorphine naloxone are available in both office-based settings and specialized drug treatment centers. That differs from the US, where methadone isn't available in office-based settings. Second, buprenorphine naloxone was made first-line treatment here in BC, unlike anywhere else in the world, in 2017. So I think it's a relevant question to ask both locally for our local clinical guidelines as well as in the US. And the fact that both treatments are offered in the same kinds of settings allows for a direct comparison. What we found was methadone, people had a much easier time remaining on treatment. Their discontinuation rate was substantially lower, 35 to 40% lower on methadone compared to buprenorphine. And the risk of mortality while people were on treatment was no different. We didn't see a statistically significant difference. That finding is important both locally and internationally. It, I think, provides a strong piece of strong impetus to make methadone available in office-based settings in the US, since it outperformed buprenorphine. Locally, the decision to make it first line, to make buprenorphine first line treatment was a greater safety profile. And while the advantage was to buprenorphine slightly, even over 10 years, we couldn't see a meaningful difference. That should persuade more and more clinicians to turn to methadone. The other piece of context I want to raise is that fentanyl was first detected in BC in 2012, and it's taken over our opioid supply, and that is a far more potent opioid. So people have much higher tolerance, and you need higher doses. Basically to eliminate withdrawal symptoms, which is the goal of opioid agonist treatment. And so really, I think what our results are telling us is that methadone is really the preferred option in the fentanyl era. A study clearly showing with a apples to apples comparison, showing an advantage towards methadone, I think makes a strong case to make it available in all settings. And I know that's of interest. Not allowing methadone to be prescribed in office-based settings is just taking a tool out of use for you in the US. So I really hope it's going to be helpful. I know the NIH was interested in this study for that reason. They needed evidence, observational evidence, true population-based observational evidence to compare performance in these medications. The notion of how we treat people with opioid use disorders really needs to be re-examined. So a lot has been static for a long time, and these clinical guidelines have been based on evidence drawn from the heroin era, pre-fentanyl era. And so we hope this study spurs a lot more similar work along these lines. Just by virtue of some of the policy changes we've made here, we're now seeing things like combination OAT, people prescribing short-acting opioids alongside a sort of backbone of methadone has shown benefits. Fentanyl patches. We need to think about how, if people are using benzodiazepines along with their opioids, we need to be thinking about how to treat benzo and opioid co-use, whether that requires a short taper, a long taper. None of these questions have yet been answered. So I think treatment of opioid use disorders, pharmacotherapies for opioid use disorders need to keep up with the changing illicit drug supply, and that's really our focus moving forward.